Good afternoon, everyone. I'm Dr. Vamsi Krishna, consultant neonatologist and pediatrician. We know that there are so many babies that we admit to our NSU because of the respiratory distress. So the causes might be different, the management might be different. So today we try to know how to approach these neonates that present with the respiratory distress to us. The object of presentation is first we'll define what is respiratory distress, what are the common causes of respiratory distress in the neonates, how do you generally manage these babies. Then we'll discuss different case scenarios with the specific management of the common conditions. So respiratory distress occurs in enough presence of two of the following criteria. Once the respiratory is more than 60, any newborn who having respiratory distress, in order to maintain the normal mid ventilation, they can't increase the tidal volume. So they increase the respiratory rate to maintain the normal mid ventilation. So they increase the respiratory rate. And they have a subcostal intercostal retractions because in order to maintain the equatorial pleural pressure, they want to use more number of the accessoring muscles for the to open up this collapsed alveoli, so that can lead to the retractions in the subcostal intercostal retractions. And they try to experiment as a partially closed glottis in order to develop the inherent teeth that may be around 3 centimeters of water, so that presents the respiratory gland. So out of three following criteria, if the two criteria are present in a baby who is in quiet state, and we after recording the respirator for 1 minute, then this is called as respiratory distress. So the respiratory is one of the most common problem in emergency in NSU. Nearly one third to the half of the admissions of the NSU because of the respiratory distress. The lung mechanisms and the risk factors are different in the children compared to the newborn compared to the older children. So the management is also different. The newborns have very short neck with a long tongue, large tongue with narrow passages which can obstruct the airway easily. The resistance has been inversely proportional to the 4 power of the radius. These already have a small radius containing the airways, and any further compromise because of any secretions or infection can lead to increase the airway resistance to out of proportion nearly to the under power of 4. The infant ribs are oriented more horizontally compared to the adult. The diaphragm is flat, so the muscles are not traveling the long distances compared to the obliquely placed, so the strength of the muscles will be much less compared to the adult. The infant rib case is much compliant, softer because of the ribs are itself are very fragile and the muscles are not that strength. The proportion of the type 1 fibers, which are the fibers that are less fatigability with more strength and more myoglobulin, are much less commonly present in the preterm babies, around 10% and nearly 25% full term, and even the 2 years baby they're 50%. So they have the poor quality of the type 2 fiber that all that make the respiratory systems and the respiratory muscles in a less benefit way compared to the pediatric and adult population. So most commonly the respiratory diseases happen in the preterm infants, infant born to the birth asphyxia, infant of a diabetic mother, born to the cesarean section babies, and babies who are born to mother with the Neonates, and babies who are born with a meconic skin impact, like many other babies who have congenital anomalies, or any babies with the cardiac disorders and syndrome babies. They are the most commonly risk factors having babies who present with the respiratory distress. So the causes can be classified the pulmonary and extra pulmonary. In the pulmonary causes, so there can be upper airway obstruction like coronary atresia, Pierre-Robin sequence, and the laryngeal pathology like your laryngeal stenosis, ableutic stenosis, or you can have even this laryngeal tracheal clefts, epiglottitis, laryngeal malicious. The lower airway, you can have parenchymal involvement in the form of transient tachypnea of newborn, respiratory distress syndrome, meconium aspiration syndrome, congenital pneumonia. There can be air leaks like pneumothorax, pneumomediastinum, pneumopericardium, and there can be milk aspirations or any other aspirations that happen. In the case of extrapulmonary, it can be congenital heart diseases, it can be neuromuscular disorders where the baby might have a poor muscle tone so that the respiratory distress will be there. There can be intracranial bleeds that can be the poor respiratory effects or birth trauma, like any babies having the phrenic nerve involvement or having the rectal involvement, they can present with a stridor or the poor respiratory wall movement. The polycythemia, requirement of oxygen more, they can present more amount of respiratory distress. Hypoglycemia itself can present respiratory distress. Any hypothermia and hypothermia can present with the respiratory distress. Metabolic acidosis, in order to compensate for the acid levels, when more amount of the respiratory will be there, which can present with respiratory distress. Any baby who has a shock and a weak mismatch, these babies are also more prone for the respiratory distress. Even anemia, which is a high output state, the baby still can have a respiratory distress in order to have more amount of oxygen supply to supply to the different parts of the body. So the causes of the preterm in the first 6 hours, usually the highly malignant disease, congenital pneumonia, TTNV are most common causes. HMD and the TTNV, whenever they usually present in the first 6 hours. If the baby develops respiratory after 6 hours, HMD and the TTNV is less likely. The congenital pneumonia usually present in the first 24 hours of life. The lung malformations and the air leaks can happen at any point of time based upon the clinical situation. The PDA and the Aspiration usually happens after the 6 hours of life, and any drug dependent lesion, the doctor knows around 50% of life, which can lead to uh, problem with the shock and the respiratory distress. In the case of a term baby, in the first 6 hours of life, the TT is again the most common cause. As we discussed, that congenital pneumonia usually happens in the first 24 hours of the life. The term babies may have more prone for this asphyxias. So they usually present in the first 6 hours like the asphyxia to lung injury that usually present with tachypnea, metabolic acidosis, and can have a secondary affecting inactivation. And similar to the preterm babies, the pneumothorax and lung malformation can happen at any point of time. The drug-dependent congenital heart disease, drug-dependent lesion usually present after the 6 to 4 hours, and the meconium aspiration syndromes that happen in the case of the term babies usually present in the time of the birth. So to begin with the evaluation, first we have a proper history, then we need to examine the baby, then when you do the necessary investigations, based on it we can pinpoint what are the diagnosis. So first we need to the most important question, when a baby had a respiratory distress, is what is the gestation age of the baby? Because in a term baby, for undergoing LSAs, the TTN is the most common cause. In a preterm baby who doesn't have an anti-steroids coverage, RTS is one of the most important thing. And the post-term baby and the late preterm baby who had passed the mechanistic and amniotic fluid, the meconium aspiration syndrome is the most common cause of the respiratory distress in these babies. The next question is we need to ask what is the liker of the baby. In the case of the baby who had an oligohydramnios, the pulmonary hyperplasia is one of the important reasons for the respiratory distress. In the case of the polyhydramnios, there could be something obstructing the normal swallow of the amniotic fluid. It could be neurological things, or it could be muscle-related things, or it could be any obstruction in the airway or the obstruction in the gastrointestinal tract like CDH and TF that can lead to polyhydramnios. In the case of any mechanistic amniotic fluid, the meconium aspiration syndrome can be one of the important causes. Some of these babies can also have developed 10-50% can have the PPH that can lead to the respiratory distress in these babies. If the mother had any history of a leaking PV, choreographed false swelling like a fetal maternal tachycardia, elevated leukocyte count, these babies are more prone for the early onset sepsis, and early onset congenital pneumonia is one of the most common that can lead to respiratory distress. One should ask about the maternal UTI and the babies who have been suspected with the early onset sepsis because maternal UTI can itself lead to the early onset sepsis and congenital pneumonia. And the condition at birth, like any baby who just had a respiratory distress, the prolonged delivery can have a metabolic acidosis, elevated lactate level can present as a distress. And the babies who has been delivered with the birth asphyxia can lead to the asphyxia to lung injury. And any baby who has a resuscitation at birth can present with the air leak syndrome. And these babies are more prone for the air leak because of the pressures that have been provided at the time of birth during the resuscitation. Then we need to examine the baby. Then one of the most important matters in the newborn is the temperature. The temperature should be maintained in optimal level to avoid hypothermia. The respiratory rate should be maintained. The respiratory rate should be calculated for 1 minute. The heart rate should be monitored. The blood pressure should be monitored to assess the shock parameters. The saturation should be measured. When you should know the saturation levels, usually wanted the approx 9 to 95% will be maintained. The other signs of respiratory distress like retractions, grunting, and the nasal flaring. The baby is trying to flare the nose in order to allow more amount of the air to enter the nose. And sometimes the baby's in the upper airway normally can lead to respiratory. So these signs of the respiratory distress signs should be monitored. And when examination of the respiratory system, the first thing we do is whether the chest wall movements are equal or not, the chest is expanding properly or not, whether there is asymmetric in any chest wall movement. Sometimes you have a diaphragmatic palsy, the chest wall movement may be hampered in that part of the diaphragm, and there can be asynchrony. And we need to see whether the air entry is good, and we need to assess whether there is any additional stones are there in the breast. Then the cardiovascular system can also abnormally connect to respiratory distress. So when you whether the heart is positioned normally or is dextrocardia, whether the heart stones are normal and head in appropriate places, or whether there is any loud P2 or whether there is any murmurs, especially the PPH, we can have a loud P2 on the tricuspid station murmur. This can be seen in the preterm babies because the pulmonary pressure may be high. We need to look for the abdomen also because any CDH, the baby can have a scaphoid abdomen or any kind of the intestinal adhesion. Also, the baby have polyhydramnios, and also the baby can have a different bowel sounds. And any hepatomegaly can be noted in the babies who are having this any clots or congenital sepsis infections. The umbilicus and the nail should be looked for the meconium aspiration syndrome. If you have a meconium aspiration syndrome, the meconium is stained with the cord and the nails, it means that the meconium has been, the baby has passed meconium for more than 4 hours. It means these babies are maybe more prone for the asphyxia and more prone for the aspiration, the meconium aspiration and the meconium aspiration syndromes. And the newborn babies may have a respiratory distress second to the CNS problems. In these, the babies may be hypotonia, have the poor sucking reflex, incomplete morals. These can be related to the asphyxia, it can be related to any brain malformations, that can be related to any tonal abnormalities. So in any case of baby, the hypotonia can present with in a significant respiratory distress, but have a hypoxia and desaturation. So these babies should be assessed for the tonal reflexes. Any baby with full AF might have intracranial bleed or might have cerebral edema. These babies The cause for the respiratory distress may not be because of the lung pathology, might be because of the CNS thing. In this examination, is paramount important to identify the pinpoint what is the cause. So this is a differential thing that we can see the cause of respiratory distress in different pathology. In the case of the tachypnea, one of symptoms usually present in majority of the conditions. In the case of CNS, we can have more of the apnea. The retractions, if they're there, more of a pulmonary causes. However, in the cardiovascular metabolic, it can be there when there is a decompensation happens. The current usually suggests two of the pulmonary parenchymal involvement usually suggests the pulmonary disorder. But in the case of the CVS, where the baby is going to the cardiovascular shock, the baby can have a pulmonary edema, then it can have a some amount of the respiratory event, but predominantly current is pointing toward the pulmonary disorders. Sinuses can happen in the pulmonary disorders, and cardiovascular disorders, and CNS disorders, but metabolic disorders usually they present with a tachypnea with mild retractions, and these babies usually present with a pale colored skin because of the acid levels related to the vasoconstriction of the skin. Hepatomegaly happens in the pulmonary disorders, cardiovascular disorders, and directly seen as metabolic. And the part of the history definitely identify the lung that the point of the history will definitely guide us which system is involved. If you have prematurity or necrotic like or polyhydramnios or rupture of membrane, then pulmonary disorders are more common. If you have any history of the rubella, high drops, left ventricle failure, the more chance of the series will be there. Any baby will more from asphyxia like a breech presentation or normal delivery, babies in hypotonia, abnormal malformation, these will be more from CNS disorders. And the preterm babies, with increased protein, they can have a metabolic acidosis, and also in the baby, the IN can relate to the more metabolic disorders. Seizures present usually suggest of the metabolic or the CNS disorders. In the pulmonary seizures, usually there until the baby has severe hypoxia. In the Marmor presence, usually suggest of the serious disorder. So when we are finding the respiratory distress, I like to point out the respiratory distress cause. We need to assess the severity by objective scoring. So we have seen the Downey score where we have the 5 parameters: respiratory rate, cyanosis, grand retraction, air entry. We label the 0, 1, 2 based upon the parameters. And if it is usually for the term, but we can also use the preterm because the inter-observer variability is less. All the values are objectively assessed rather than the subjective felt like in terms of management. Any score more than 7 indicates severe respiratory distress. In this case, usually prefer for the respiratory support with high respiratory support, maybe mechanical ventilation. There is also called a Morpheton score where the people along with these parameters, 6 parameter gestation is will assess it based upon the gestation is the lower gestation is will have a higher score and higher gestation will have a lower score based upon the gestation is also adding to this we can modify the score that we can use more for the preterm babies also. The silver man score usually used for the preterm babies. So we have 5 parameters: upper chest, lower chest retractions, and deferred retraction, nasal pharynx, and the respiratory current. So anything more than 7 suggests of impaired respiratory failure. So this is upper chest retraction. So normally the babies are synchronized along with the abdomen and chest. In the grade 1, there is slight lag of inspiration compared to the abdomen. In the grade 2, there is a seesaw. So your abdomen is moving out and the inspiratory phase, your chest is moving in. The lower on the default retractions, where you can see the lower retractions are just retractions and marked retractions. The lower retractions doesn't mean that it's below the nipple. It's actually we need to see from the side of the baby, we need to imagine the mid-axillary line. So the mid-axillary line, so the retractions that are coming below the mid-axillary line, they're usually associated with the low chest retractions. The nasal pharynx, you can see minimal nasal pharynx marked as a pharynx. In the respiratory gland, one in the grade 1, you can see only with the stethoscope. In the grade 2, we can even have the gland even without the stethoscope. So in this course, usually highest course will suggest of severe respiratory distress. The management, we need to manage for the respiratory support in form of oxygen or NAV or CPAP, or invest with the mechanical ventilation to provide the support to care by monitoring the heart rate, perfusion. We monitor the sugars, temperature, the saturation should be monitored, and the feeding should be initiated as early as possible because the absence of the enteral nutrition can lead to the translocation of the bacteria from the gut that can lead to the more amount of the sepsis. And if not possible, the total nutrition should be because any respiratory distress for the baby to cope up with respiratory distress should have adequate amount of calorie, proteins in the calcium and other minerals. And we need to identify the cause and then we need for the specific therapy. So these are routine management policy for the algorithms. So we need to assess the temperature, assess the circulation, and monitor the temperature and circulation based upon that we will be correcting. We maintain the neck in the stiffened dog positions in order to make alignment of the airway. We clear the secretion as well liquid. We administer the oxygen to maintain the normoxemia. And we examine the respiratory distress features. We calculate the Donis and Simpleman underscores. We locate the pathology based upon the clinical assessment and also based upon the X-ray. So we adjust the fluid and electrolytes so that the abnormalities are corrected. With the preterm babies, wait early. If the babies are having good respiratory efforts, not in a worsening shock, we start with the CPAP, we do the surfactant, and with the babies are the risk factor for sepsis, we take a culture and start the antibiotics. If any failure of the CPAP, any worsening distress or worsening blood gas and hypoxemia, we start the babies on mechanical ventilation. In the case of terminal preterm, the baby has a poor respiratory effects, worsening shock, PPH, massive pulmonary embrace, CDH. The apnea does not respond to the bag and mask ventilation. Either in the term or the preterm, we directly go with the mechanical ventilation. If in the term baby, if they don't have present only the respiratory system, we can start with the CPAP and we can escalate the mechanical ventilation if there isn't worsening the respiratory system or metabolic acidosis or respiratory acidosis worsening blood gas. We start with oxygen therapy when the baby has central cyanosis, hypoxemia, respiratory system, irrespective of the cause. Saturation targets usually prefer the 91 to 95%. We provide a pre-warm on the humidified oxygen. The excessive flow can cause the turbulence in the airflow and uncontrolled breath and may can lead to the local airway injury. So these are various oxygen delivery systems. Nowadays, we are not using all these delivery systems. The oxygen previously for the mechanized system, where you need about 10 to 15 liters, will provide in advance 80 to 90 amount of oxygen. Some amount of flow is required. This high flow can lead to more amount of the crusting and the damage to the baby. Whereas nasal canal and nasal pumps, where 1 to 2 liters can provide the FIO to 25 to 45%. So nowadays, we are not using all this kind of things. We are using either HFNC or we are using either CPAP for the delivery of the oxygen. The CPAP is providing the continuous disturbing pressure in contact to the P variant in the ventilator will provide the positive and expected pressure at the end of the expiration in the CPAP. It will provide a continuous disturbing pressure throughout the respiratory cycle both during the inspiration and expiration. So the ideal time of using the CPAP is the continuous disturbing pressure rather than the P. So we start with the CPAP any baby who requires respiratory distress. We start with initially 5 centimeter of water and we adjust the FiO2 based upon the SpO2 targets for that point of the time. And always we start with the blender. So we start with the CPAP and we allow up to 20 minutes, we allow for the chest expansion, we'll see the blood gas and the SpO2 levels. If you are underintubated where the worsening of the respiratory distress are there, with the form of retraction in grunting, the chest expansion access to low lung volume, we need to increase the CPAP per centimeter. For inflation, we'll see by the clinical movement, we repeat the blood gas. If the clinically baby is improving, we'll decrease the CPAP per centimeter. If the baby is worsening, then we need mechanical ventilation. If there is any signs of overinflation or chest wall hyperinflation, then we need to decrease the CPAP by 1 centimeter of water. Then in case of mechanized we can see that baby on the respiratory distress, but distress are used to overinflation where we may decrease the CPAP by 1 centimeter of water even though the respiratory distress is still present because the mechanism there is not because of the collapse of the alveoli, because of the partial or valvular obstruction of the airway. So if your CPAP is adequate, then your respiratory distress will improve, the retraction will come down, the grunt will disappear, and the baby look more comfortable, and there is a reduction in the FiO2 requirement. Sometimes in the babies, we may see that babies who are there will be decrease in the grunting, there will be decrease in the intercostal retraction, but your FiO2 requirement will increase. That indicates that baby is not actually improving, the baby is actually tiring out because of the continuous efforts. So both of these should go hand by hand. Along with the improvement in the respiratory distress scores, your FiO2 requirement should also will improve. And if you see the blood gas, we can have a normal PO2 and PCO2 levels. And if you do chest X-ray, the X-ray should have a normal lung expansion. Mechanical ventilation, when you have a continuous CPAP, when you have a progressive respiratory failure, a high PSU at more than 60, pH is less than 7.2, you're not able to maintain oxygen at 60% FiO2, there is severe hypotension requiring more than 2 inotropes, the baby is having a severe airway malformations, the baby has a frequent apneas and bradycardia, not improving by the CPAP and AV. These are the indications for the mechanical ventilations. Ideally, but nowadays we are majority of the times we are trying to avoid the mechanical ventilation. We are providing for the non-invasive ventilation. So we'll monitor for the oxygen saturation. We'll do the ABGs or CBGs for the metabolic respiratory acidosis and alkalosis. We send the sepsis marker like the blood counts, CRPs. We monitor the glucose level. We see the chest X-ray when and required to look for the air leak, for the collapse, for the cardiomegaly. And in the case of preterms, previously we do the shake test, but nowadays we are not doing all these things. So now we discuss the few case scenarios. So what is the X-ray? So this is actually a normal X-ray. So the normal X-ray usually we take in the newborn is the AP view. So this is an AP view of the X-ray. Then we see the diaphragm is up to the 6 ribs anteriorly and the 8 ribs posteriorly. Here we can see this normal X-ray. These are posterior ribs which are connected to the vertebrae. So normally 8 to 9 vertebrae is so these are 1, 2, 3, 4, 5, 6, 7, 8. So these are the 8 ribs are there, so suggest of good inflated. 8 to 9 is good inflated, less than 7 is uninflated, more 10 or more than 10 is suggest of the over inflated. So ideally we want on 8 to 9, so this good inflated X-ray. And the ribs are more horizontal compared in the children. As we discussed already, the normal situation in pediatric is usually take 0.5, but in newborns will take 0.5 because we are exposing in the AP view. In the AP view, the heart comes to the head, so your heart might appear a bit larger than the normal. So 0.6 is the cutoff for the cardiac respiration. Some few amount of 8 micrograms can be in the retrocardiac area. So these are the retrocardiac areas where you can see the few events. These are the normal. The thymus may be prominent in some X-rays, so the sales in one need to be have an idea before commenting anything. Otherwise, we may inadvertently lead to the abnormal reporting on the X-ray. So first case scenario where the preterm may be 130 weeks of the gestation by preterm vaginal delivery with mother having no antenatal visits and no steroids. So after the delivery, baby has respiratory distress with intercostal retractions. However, mother doesn't have any sepsis risk factors. So what is the diagnosis? So this is a straightforward case, preterm without any antenatal steroids, no risk factor sepsis. It could be the respiratory distress syndrome. So what is the specific treatment? So this is an X-ray of the baby. So here in X-ray we can see that there are fine reticulogranular patterns are there. There are few amount of the 8 bronchograms. So this usually consists of the respiratory distress syndrome. For respiratory distress syndrome is homogeneous disorder. Previously, the proper X-ray findings are low lung volumes. However, because of the early utilization of the CPAP, we may not have a clear-cut respiratory distress syndrome X-ray that we need to hear in the previous era. So the RDS is because of the most common respiratory distress problem in the newborn. It is because of the decrease or inappropriate surfactant productions or inactive surfactant. Preterms are more common the male sex because of the testosterone will inhibit the action of the surfactant, and the maternal diabetes is the poor quality of the surfactant. Any birth asphyxia can lead to the metabolic acidosis and inactivation of the surfactant. The pulmonary mechanism aspiration lead to secondary inactivation of surfactant. So we need to the respiratory distress usually within for 6 hours because of the alveolar collapse and atlectus and VQ mismatch. When the previously the X-rays used a low lung volume with homogeneous ground glass and 8 bronchograms. Nowadays, because of the early application of the CPAP the delivery, we are not able to get this kind of the pattern. The traditional the RDS usually used to resolve by 2 to 4 days of after the treated adequately. We used to be told that once the baby start passing increase in the urine output around 2 to 4 days, it means that the RDS is usually getting resolved. However, because of the use of the CPAP, the babies might be getting improved even much earlier. So there are 4 stages of RDS. So in stage 1, based upon the X-ray, we have fine reticulogranular pattern that we have seen. The stage 2, there is soft decrease in the transparency along with the reticular pattern. We might have a prominent embark not in the retrocardiac areas. And the stage 3, we have a much more decrease in the transparency and you have a blurring of the diaphragmatic cathode. In the stage 4, we have white outline. So in the previous X-ray, we have seen that in stage 3, because of there is a reticular patterns with 80 bronchograms along with the decrease in the transparency with the blurring of diaphragm. Previously, we used to do a shake test where we used to all the premature babies within first 4 hours of before feeding. We used to take 0.5 ml of the gastric aspirate and we used to mix with 0.5 ml of the absolute alcohol in the glass tube. We shake to 15 seconds and allow it to 15 minutes. So based upon the bubbles, we used to grade the RDS. 0, no bubbles with 60% of RDS. Grade 1, very small bubbles extending the 1/3 or less than 1/3 of distance of the test bubble, 20% of RDS. 2 is single rim of bubbles. 3 is rim bubbles all the way around the test tube with a double row in some areas. 4 is double rows or more than this. So 3 and 4, the chance of RDS is less, and 0 to 1, the chance of RDS is more. However, the shake test is not valid nowadays. Majority of the centers we are not doing because we have much more chance of earning the identification of the RDS. And then the shake test will be fallacious if the blood and mechanism stain is there. We have a lung ultrasonography. We have done a lung ultrasound session in the previous maybe around 1 month back. So we can see the lung ultrasound pictures in the RDS and what is the normal lung ultrasound. We're just briefing the lung ultrasound in the case of RDS. In the case of the lung ultrasound RDS, we have a lung consolidation and the air bronchograms, the ALS eruption. There is a thick and irregular pleural subpole consolidation. Sometimes the non-consolidated alveolar distichial syndromes can present in 15 to 20%. They have a bilateral unilateral pleural effusions. So here you can see this thing. There's a thickened pleura is there. There's a diffuse B lines are there. There's subpleural consolidations. So in this image you can see that there is a thickened pleura and the subpleural consolidation and the B lines are there. This is the characteristic of the respiratory distress syndrome. So here also we can see this air bronchogram. The subpleural consolidations are there, and there's an air bronchogram which appears as like a dot bright kind of things that present in the lung. So we have a lung scoring system. The score A is a normal where they have a normal pleural with the reverberate A lines. In the case, in the score 1 is where you have a 3 or more B lines. In score 2 where you have the presence of the crowded and the coalescent lines with or without subpleural consolidations. In the stage 4 is consolidations extending into the lung parenchyma. So we have score from 0 to 18. The mild is 1 to 6, moderate 7 to 12, and severe is more than 12. So we always try to do the lung ultrasound. If the score is more than 8, we'll do the products affected by LISA. LISA is a newer technique of products affected without intubating by the LISA catheter because the decreased chance of the mortality, decreased chance of bronchopulmonary dysplasia, and decreased chance of severe intraventricular hemorrhages. So we provide surfactant. Surfactant was given as a baby. Surfactant need to be given as a baby is requiring more than 30% of FiO2. on CPAP of 6 centimeters of water as per the European Consensus guidelines, we usually surfactant of within first 2 hours, no problem surfactant, because of surfactant, liquid mortality, no chance of air leak. Surfactant alpha is the preferred of surfactant that we usually because the volume is less and less than the BPD, PD, and mortality. These are the technique that better gives surfactant because the chance of death, BPD, and IVH. So this is a Lisa catheter where we can, with other than intubating the baby, we open with laryngoscope, we see this airway and we can insert this just beyond the your epiglot, beyond the your vocal cords, and then we can do the surfactants. In this way, we are avoiding intubation, post-operative ventilation, and thereby decreasing the chance of pulmonary dysplasia. Even few breaths of 3 to 5 also can lead to the increased chance of pulmonary dysplasia. So usually it must do the rescue surfactant therapy and so providing the CPAP, the late rescue more than 2 hours, usual rate in inbound settings. So nowadays where majority of the centers are giving the rescue surfactant, the early rescue surfactant. Sometimes the baby has been born somewhere and been brought. Outborn babies may little receive late surfactants. And one of the common surfactants is that they can lead to the block of the airway obstruction. There can be hypoxia, there can be desaturations, bradycardia, there can be air leak. If you're not able to wean out the pressures, you need to do surfactant because the compliance will increase. In this way, the leaking mode of ventilation must plays a major role. And sometimes because of the surfactant, the lung compliance improves and there is a large amount of the blood circulating from the left direction that can lead to the more of blood entering from the lungs and pulmonary. So next case, the term baby born with LSCS, mother had no labor pains, completely no. So this is the X-ray where you can see that there is mild hyperinflated lung with a fissure, fluid in the fissure, and we can see this is very high leaking in the form of sunburst appearance. So the classical picture of the TTL. So TTL is the most common distress in the term babies, usually present birth or shortly after the birth. The late preterms, lack of any initiation of the labor pain, diabetic mother, electro LSCs in the male gender subgroup of the TTL. It is because of the ineffective clearance of the food from the lungs, because of the failure of the switching of the ambulant and sodium channels from the secretory to the observatory phase. The baby is usually present in first 6 hours of the tracheotomy, mild retractions, and sinuses usually respond well with the oxygen with less than 40%. Sometimes there can be maybe more severe babies might be associated with any other part of the RDS or any asphyxiated lung injury, there the babies might require even CPAP treatment. So in dual test X-ray, we can see that the predominant period streaking in sunburst appearance, there is a hyperinflation and there is a fluid in the fissure. So when you do the lung ultrasonography, we can see the compact P lines with the normal pleura without any consolidations. The pleura is regular, and we can see the double lung pond. So these are taxidecapnia in the alveolar distribution presence is a double lung pond where you have a lower lung with alveolar distribution pattern, upper lung where you not only a pattern. This distribution pattern double lung pond is a characteristic taxidecapnia. So next we have a male term baby among LSS 42 weeks with the Mecklenstein Liker. Mecklenstein Liker with respiratory distress with no stuff and leaking PV and metal fear. What are the damages? When a baby is born with a Mecklenstein Liker and have a respiratory distress without any objective evidence, we should consider this kind of respiration mechanism as specialist. So it's a characteristic mechanism where you have a heterogeneous opacities with consolidations and retractor patterns and hyperinflated lungs. This is really such of the mechanism aspirations with the mechanism. So mechanism most common in post-date and the later infants, 10% of the dead bodies have mechanolytic fluids in this way in these age groups, 54% of mechanoaspirin syndrome, 50% is symptom. Mechanoaspirin maker in vitro intrapart and the post-mortem period. So there can be post-date because of the physiological mechanism passage, because of fetal compromise, because of the hypoxia, cord compressions, or because of any other asphyxia. There will be reflex passes of the meconium. This meconium is an amniotic fluid, can be a postpartum aspiration or in vitro gasping. This can obstruct the peripheral airway, complete obstruction, atlaxis, leaky mismatch, and the partial obstruction that can lead to the valvular mechanisms. Because valve during the inspiration will be the air enters, because during inspiration the vessel because of the contraction of the respiratory muscles, the airway diameter increases during the expression. They try to the elasticity, because of elasticity they try to recoil, then the air may not increase to the small airway that can lead to the valve mechanism that can lead to the air trapping and the air leak. Or it can be sometimes the proximal obstruction that can lead to the complete obstruction that can lead to all these can lead to hypoxia and hypercapnia. Or this mechanism can go down into the due to the alveoli that can lead to the chemical immunity surfactant activation. But because of this prolonged compromise, the complete compromise, the remodeling of the pulmonary vasculature can be there. These are all things can lead to the persistent pulmonary hypertension, both because remodeling pulmonary vasculature and this hypoxia, hypercapnia, and acidosis can lead to reflex pulmonary vasoconstriction that can lead to pulmonary vascular hypertension. So then, when you get this the mechanism, the mild is less than 40% or less than 48 hours, moderate is more than 41, more than 48 hours without any airlift, and severe is who require restricted ventilation for more than 48 hours and with or without PPH. The respiratory distress will be there. Next day, we can see there's hyperinflated chest, atelectatic, asymmetrical patch infiltrates, and the air leaks can be there. So this X-ray picture in lung ultrasound, we can have the different kind of the picture. We can have the consolidation, air bronchograms, and we can see this air leaks. All the things can be seen in the patients. So we do just X-ray. We do the immediately after the previously we used to do the routine suctioning. Nowadays we are not doing the routine suctioning. We are providing the hospitalization when required. No chest physiotherapy. CPAP should be provided with caution. When maybe had a grunt with a distance only antibody CPAP that you suggest other, there is a reflectant inactivation has happened. And the baby has a hyperinfiltration without any grunt. We do not have to the CPAP because it can lead to more amount of weight trapping and it can lead to more amount of pneumothorax. Surfactant can be given in a mechanism syndromes who are required more than 40% without having a hyperinflated valve kind of mechanisms. The leaks are much common in the mechanism syndromes. Nearly 1/3 of the babies can develop PPHN and in future they can develop BP in 5% of the cases. The same baby or mechanism syndrome develop around 10 hours old, developing the worsening respiratory distress with level saturation without beating with the preductal postductal saturation of more than 10%. What is your immediate answer? So any baby mechanism syndromes with this kind of picture, one should expect the PPHN. So PPHN is because of the disruption of the normal perinatal fetal multi-circulated transition. There is sustained PVR elevation in here rather than normal. The PVR will decreases at after but the risk factors are the PPHN at the post-term, mechanism amyloid, birth asphyxia, maternal diabetes, and the pulmonary hypertension. So in majority of them can be due to the pulmonary vascular remodeling and pulmonary vascular remodeling mechanism syndrome that can lead to decreased nitric oxide and also the acidosis that can lead to the more amount of the pulmonary vascular constriction. These are all into PPHN. Usually present in first order differential cyanosis, preductal difference can happen, but it may not be applied to the shunting is happening at the level of the PFO. Echo should be done in all the suspected cases, and you should manage with adequate ventilation, recruitment, INO, milrinone, sildenafil, and support to care in medium normal blood pressure, normal volume, normal temperature, normal sugar, normal acid level, calcium level, magnesium levels. Mortality is much more important than in the availability of the early onset of the INO. In any OA more than 20, we should start with the INO as early as possible, or we refer to centers where the INO is there so that early initiation of INO has decreased the chance of using of the key. So the same baby after the mechanical ventilation of INO deteriorates further, we learn an X-ray. What is the X-ray picture? So this X-ray picture is suggestive of the air leak. So this is here is the air leak. So any baby has certain depression of the ventilation could be lead to the pneumothorax. Any baby who had a severe respiratory distress in form of RDS, mass, these babies who present with tachypnea, grunting, inflection, asymmetry in the breath sounds, decreased breath sounds on one side and normal on other sides. When you do an X-ray, we can have this hyperlucence, hyperinflation, we'll shift immediately shift to the opposite side and the corresponding lung will get collapsed. This suggests of pneumothorax. So in the case of pneumothorax lung ultrasonography, we can see this. This is called as a pleural sliding sign. There is no pleural sliding. So this pleural slide, this is the part where the pneumothorax is there. We have a clear cut A line. There is no B lines. And this part where we know that this part one side is lung sliding and not sliding. This is the area of the line of the pneumothorax called as the characteristic of the pneumothorax. If you put a ring mode in normal line, you can have a seashore sign. In the case of a pneumothorax, we can have a barcode sign because there is no air movement. We can have this barcode sign of stratosphere. So it's actually to be more clear, it is called a stratosphere sign because in stratosphere the layers appears like this. So it should be called a stratosphere sign. The pneumothorax, you can do the transformation by putting the cold light on the babies. Usually, if the brilliant transformation is happening, the pneumothorax happen immediately. The baby is unstable. You need to train immediately with the needle thoracocentesis, and after this, we need to put an ICD with underwater cell to have a draining of the pneumothorax. Sometimes the pneumothorax can progress to the pneumomediastinum, pneumopericardium. This is a picture where you have pneumopericardium surrounding from the heart. This can again compromise the cardiovascular and not code for the shock and the mediastinal shift can happen. So if the baby, this is another case where the female being born at normal vaginal term gestations with history of leaking the mother for 36 hours. The baby had fever and baby had desperately 66 minutes of life, then the postal traction at days of. So what are the diagnosis? When a baby who had risk factors for sepsis, one of the differential diagnoses along with either TTN or the RDS will be the congenital pneumonia. So these babies with the excess of a patch, the consultations in the right upper part of the lung. So any risk factor like problem more than 18 24 hours, maternal fever of more than 30 degrees centigrade, false smelling liquor, meconium stain liquor, maternal history of sexual transmitted diseases, we need to consider the pneumonia as a possible features. And the excessive patch infiltrates or bilateral diffuse granular patterns, sticky densities can happen. Sometimes they can be low lung volume. Congenital pneumonia can actually mimic in a case of preterm babies like an RDS. So one should be particularly clear whether it's RDS or pneumonia. If you have a risk factor for sepsis, we need to start antibiotics. You can do the lung ultrasound. You can diagnose the pneumonia from the RDS and TTL. In the case of a pneumonia, we can have a irregular days of consolidations, and it's called these irregular areas of consolidation that shed sign. We have a dynamic air bronchograms are there. The pleural abnormalities is there. There can be hepatizations, and there plus or minus pleural emphysema will be there. So pneumonia we need to treat with antibiotics, support the respiratory support, send the blood workup, and we need to provide supportive care. So this is a condition where you have this loops of the intestine in the chest wall, the deviation of the tract, deviation of the mediastinum to the opposite side. So this is a case of the congenital diaphragmatic injury. So more comes in on the left right, respiratory stress, tachypnea, nasal flaring, grunting, decreased breathing on the affected sides, may hear the mouth sounds on the affected side, the heart sounds are heard on the opposite side. And scaphoid abdomen is one of the classical signs because the intestines have been migrated into the chest. The abdomen is usually having the scaphoid. So CDH usually where it has associated defects, there were prognostic factors need to be assessed. The other anomalies need to be assessed. The baby should not be given bag and mask ventilation of the immediate intubation, and very high poor prognostic CDH can also mean the ECMO. The surgery is not a paramount important. This thing for the stabilization of the cardiovascular and the respiratory is important. When the babies are in stabilized cardiovascular and respiratory, we can do the surgery even after 24 to 48 hours. So with medical messages are early identification and appropriate protocol based management is important because different in the newborn, different condition, different systems may lead to different kind of the respiratory distress. As we've seen how to differentiate between these. Once identified this thing, we need to have a clear cut antenatal history and we need to have a detailed examination in order to pinpoint our diagnosis to the system that we are involving, and based upon that we can do the investigations. On the timing of onset respiratory is important because we cannot label a baby with RDS in the baby current after 48 hours. So with this I conclude my presentation.